The content of my slides are, the number of my slides are not many, but each slide is will require me to go slow. So that is how I may take the whole of 45 minutes that you have allotted me, and I hope that I do not exceed that time. I'll keep that in mind. Now, just consider this case scenario, and I'm sure everybody will identify with this kind of case coming into their OPD. You have a 2.5-year-old boy who's brought to OPD with concerns about tendency to throw tantrums. Mother reports that her child is not yet talking. She has not been too concerned about this because the child's father was a late talker and they live in a bilingual household. Although the boy has had several episodes of ear discharge, she feels strongly that there is no question of hearing loss because this child seems to understand whatever is spoken to him. So this is a very common scenario. And as pediatricians, uh, we all know that most all developmental milestones have a range of normalcy, and language milestones have the broadest range. So the biggest challenge to pediatricians is to decide whether to give importance to this particular complaint of not talking, or whether to go with the parents and say that the child will catch up by and by. No intervention is required. So in the next 40 minutes or so, I hope to make it very clear to you when to be very concerned about such a complaint and when to just reassure the parent. Now, when we consider the possibility of not talking or delayed talking, there are a set of common conditions that immediately come to mind, and these are the conditions that we need to investigate if we decide to pursue. Obviously, the first thing all of us should think of is to test hearing. Now, when it comes to testing hearing in a child with delayed language, what we all must remember certain facts. I mean, it's not just a question of sending the child for a hearing test like BERA and you are done. You must remember that first of all, all children, even those who have had hearing tests done in the neonatal age, for some reason or the other, they must be routinely evaluated at the age of 24 to 30 months, irrespective of what their language milestones are. This is very important because there are many types of hearing defects which appear at later age, even though the onset or the etiology must have occurred in the intrauterine or perinatal period. The actual hearing defect appears later. So even if the baby has undergone neonatal screening for hearing, if such a child comes to you with complaints, but ideally all children without complaints also must undergo hearing assessment at the age of 24 to 30 months. BERA, remember, rules out all hearing defects except mild deafness. The investigation of choice for screening is BERA, or what is known as otoacoustic emission. Most people do both. Most clinicians, they recommend both. But there are guidelines which say, especially Indian guidelines, which say that you use otoacoustic emission for the simple reason that it is a less costly tool, doesn't require sedation, and it picks up sensory neural as well as conductive loss in the neonatal period. And BERA can be used as confirmatory. But what I would like to inform here that it is not just one test which should be done to rule out hearing. A battery of tests is what is required, both objective tests like BERA and otoacoustic emission, plus behavioral tests like the visual reinforcement audiometry or speech reinforcement audiometry, pure tone audiometry. These are all behavioral tests. Both are required to definitely rule out hearing impairment. If for some reason BERA is not available in your area of practice, and somebody has OAE, then OAE plus behavioral assessment put together can be confirmatory, and BERA then is not required. But a caution about OAE, remember that otoacoustic emission rules out conductive and sensory neural hearing loss, but if the sensory neural hearing loss is because of auditory neuropathy, then it will be missed by otoacoustic emission, because OAE detects functioning of organ of corti, the cochlea. It doesn't detect functioning beyond the cochlea. So if OAE alone is used, then it is still not adequate to rule out hearing impairment. Auditory neuropathy is very often the only cause for deafness in babies who have spent time in NICU. And hence, babies, high risk babies, their hearing assessment should not be done with OAE. It should be done with BERA. And of course, if it is if the child comes with delay in language, then even BERA alone is not sufficient. As I said, you need to do a battery of tests, and hence sending the child to an audiologist is more appropriate than sending the child just for a BERA test. So, having discussed a few facts about hearing tests, let me go to the other end of the spectrum of etiology for delayed speech, and that is the output. We just discussed the input problems in language. Few facts about the output problems. You have to consider two conditions: dysarthria and speech dyspraxia. Dysarthria is very easy to rule out. It is a inability to speak because of muscular dysfunction of the oromotor apparatus, and this is usually as a result of some kind of brain injury seen commonly in cerebral palsy and ataxia and different types of birth injuries resulting in damage to the relevant areas in the brain. So you just have to do a neurological examination, and then you can assign the reason for delayed speech as dysarthria. What is important to remember is the condition called speech dyspraxia, which is extremely rare, but it is very important to pick up. Dyspraxia means inability to execute a motor function despite having a normal motor apparatus and despite retaining the ability to do that motor function, but on command, the person will not be able to speak. Now, this is speech dyspraxia, and it occurs because, as I said, because of inability to execute a command involving the muscles of the oromotor apparatus. Now, speech dyspraxia can be tested in the OPD by a simple command. Ask the child to perform movements like blowing, tongue protrusion, licking, or repetition of labels. If the child has difficulty in doing them, but he will be able to protrude the tongue as a function of, let's say, while eating an ice cream. But when you ask the child to protrude the tongue, the child will not be able to do it. This is speech dyspraxia. And speech dyspraxia is because it involves the same muscles of oromotor apparatus are required for eating, drinking, chewing. Such children will have difficulty in sucking and swallowing. So you should ask history of difficulty in feeding as well. Now, ask about delay in onset of babbling. Remember, this begins at around 6 months of age. And all children, even those who have severe hearing impairment, will definitely have babbling at the age of 6 months. It is very rare that a child of with any problem will related to language will not have babbling. And speech dyspraxia is one condition where an infant cannot even babble. So this is a very important history to rule out speech dyspraxia. As I said, it is an important condition to pick up because the treatment approach for speech dyspraxia is very distinctive. So once you identify this condition, this child can be sent for that particular management protocol. And hence, I took some time to talk about speech dyspraxia, even though it is a very rare condition. So we have discussed about input and we have discussed about conditions related to output of speech and language. Now I come to the most important causes of speech delay in children. Conditions. Now, prerequisites for spoken language are, we all know, hearing and auditory discrimination, but it also requires that the child should be able to do what is known as encoding and decoding. Encoding means whatever we see, whatever objects or actions we see should be able to convert into a word. And decoding means when we hear a word, we should be able to convert it into object or action. So all this is done in different parts of the brain, and this is affected in different ways in these three conditions. So these form the final list of causes which affect language development, and I'm going to take each of them separately. First, I'm going to take intellectual disability. Now, intellectual disability is very easy to diagnose if it is in the moderate to severe category. Such children are diagnosed even before the age of 2 years. We are only concerned about intellectual disability which is in the mild range. These children are very often not picked up as cases of intellectual disability till they go to school. And the commonest presentation of mild intellectual disability is language delay. Now, definition of intellectual disability has changed drastically. It is no longer defined or classified based on intellectual quotient, IQ scores. So you please do not send the child for IQ testing if you want to diagnose intellectual disability. DSM-5 criteria says that intellectual disability exists when the child has impairment in what is known as adaptive skills. We all know that there is a developmental domain that we are supposed to assess, and that is the domain of adaptive skills. What is adaptive skills? They are a set of skills which are required for an individual to function effectively in daily life. So intellectual disability is diagnosed, defined, and classified based on impairment in adaptive behavior and not based on IQ scores. In fact, absence of adaptive impairment rules out intellectual disability even if the IQ is less than 70. So this, having understood this, when we have a patient in whom we want to consider possibility of intellectual disability, we have to look out for certain milestones which denote cognitive ability and which denote adaptive ability. Now, this is not very easy to do in an OPD practice. Ideally, such children should be sent for a very formal developmental assessment, which has cognitive domains and adaptive skill domains. But if you were to do it in your OPD, then what are the milestones you should look for which denote cognitive ability? Now, these are some of the milestones which can easily be asked or observed in your OPD. Like at 1 year, this child should be able to play imaginary games like talking on a mobile phone. At 15 months, you see this child imitating strokes on paper. When a child can take any object and imagine it to be something real, that is known as imaginary play. You see this child making a train out of a set of cubes when it was demonstrated to it. A child who can look for hidden toy suggests cognitive thinking ability. You see this appears at between 10 to 18 months. Other skills of requiring cognitive ability are relating one thing to another. For example, you should ask the child to point body parts on a doll. This comes at around 18 months, not itself, on a doll. So the child is able to relate that another object can also have eyes, nose, ears. A, if a toy is broken, a 21-month-old should be able to instinctively put the parts together, may not be accurately, but they should be able to understand that they are two parts of one. And of course, at 2 years, a child should be able to understand prepositions like under, over, in front, and behind. Some other cognitive ability are, for example, again, you can use cubes to test the cognitive skills of a child. At 2.5 years, a child should be able to, between 1 year to 2.5 years, child should be able to build tower with cubes. Manual dexterity, which is fine motor skills, is also an important part of cognitive skills. So any complex task requiring precision is also a expression of cognitive ability. So ask a child to take out pellets from a small bottle or putting beads on a string. Another important skill is to differentiate objects by their use or shapes. Like ask a child to distinguish between a cup, plate, and glass. The child should be able to know what is a glass and what is its use and how it is different from a plate or a cup. This ability comes at around 20 months. And differentiating between a vertical stroke and a horizontal stroke appears to be a very simple task, but it is a very, very important cognitive milestone for a 18-month-old. So these milestones can be easily assessed in an OPD with minimal set of equipment. And if they do not appear at the designated age, you can predict that the child needs cognitive assessment. Now, I told you adaptive skills. I told you adaptive skills are skills which are required to function effectively in day-to-day life, and they are broadly divided into three categories: conceptual skills like basic concepts in reading, writing, and number; practical skills like dressing, toileting, eating, and mobility; and some social skills like interpersonal skills, self-esteem, gullibility, ability to obey laws of the society, and avoid victimization. Now, DSM-5 criteria says that to be labeled as intellectual disability, a child should have impairment in at least one of these three categories of adaptive behavior. And these are, as you see, they're age appropriate. So sometimes it may so happen that a child with intellectual disability may not demonstrate delay in adaptive behavior at a particular age, because as the child grows, the adaptive skills become more and more challenging, and it is then that it is revealed that the child has intellectual disability. And that is why many times diagnosis of intellectual disability is delayed up to school years and even probably up to adolescent age, when complex challenges face the child and the child is not able to perform. So, having considered the possibility of intellectual disability and performing certain tests, you find that the child has a good enough cognitive ability. You move on to the second condition, which affect language development, and that is autism spectrum disorder. Now, one would think that is it a very uncommon condition? Now, I would say that it is uncommon only if you do not know how to identify this case. Otherwise, autism spectrum disorder is extremely common. In fact, it is scaringly common. The prevalence is, even in India, it is stated to be 1 in 50 children. Now, this is the reason why every pediatrician should be able to pick up autistic children. Now, we all identify autism with symptoms which are attributed to the most severe category of autism spectrum disorder, that is lack of eye gaze. Let me tell you, children with autism can have eye contact. What you need to look for in a child with autistic spectrum disorder is that a spectrum of social communication, and you can pick up these behaviors, lack of social communication, by asking these 5 questions. Does your child respond to name? Remember, children with autism have a normal hearing. They can hear other sounds, but they will not respond to name. You can ask, does your child ever use its index finger to ask about or to show something? Or when you point at something, does your child follow your gaze or finger? Does your child ever bring a toy over to show to you? Does the child pretend to talk on mobile? This symbolic play is also a very important uh, feature for development of social communication. So it is lacking in children with autistic spectrum disorder. And of course, does your child take turns in ball play or hide and seek? Now, these questions constitute the core of the social reciprocity and social communication that these children with autism spectrum disorder lack, out of which the second and the third, pointing a finger to an object, drawing an adult's attention towards that object by pointing a finger, or sharing a toy with another person. These two constitute a very important milestone, which is known as joint attention, which comes between 9 months to 12 months. And children with autistic spectrum disorder do not develop this joint attention. Now, DSM-5 criteria defines autism spectrum disorder as having impairment in social communication. In DSM-4 criteria, language was also an important component of diagnosis of autism spectrum disorder, but it is being removed as a diagnostic component in DSM-5, because children with autism spectrum disorder can have normal language. They may have no language development at all. They may have delayed language. They can have, or they can have regression of language. But when they have language, their language is atypical. It will be spoken in a monotone or a sing-song voice. There is there is echolalia, and there is an interesting phenomenon known as pronoun reversal. What these children tend to do is, before the age of 3 years, instead of saying I, they say you. They address themselves as you or her or she in third person. And after 3 years, they will address themselves by name. They will not be able to use the personal pronoun. They also tend to use a lot of TV type of language, where a whole chunk of dialogues are repeated by children in the as if it is their form of social communication. These children do communicate only when they need to. And even then, their communication is very peculiar. They communicate through physical action. That is, they take a hand of the adult to a pot of water when they need water, without accompanying eye contact or spoken word. This I have found to be so consistently present in most children in whom I suspect autism. When I ask the mother, does the child ask for water? They immediately say yes. वो पानी मांगता है. Then you have to refine your question and ask them, how does he ask for water? Does he point towards water? They say, no, he goes and stands near the pot of water, or he takes my hand and puts it on the pot of water. Now, this is not considered as atypical by most parents. So it is up to us to really specifically ask this question. And because it is suggestive of autism spectrum disorder. Now, these children also don't like to be cuddled. But remember, they themselves may go out and cuddle others. Children with autism spectrum disorder may like to go and hug others. But in return, if they are hugged, they don't like it. So these are some questions that you can ask the parents. I told you two important, in fact, there are four key behaviors which are lacking in children with autism. They are joint attention, imitation. Third is affective, emotional reciprocity. They will not smile back, they will not make facial gestures. And the fourth is pointing. So joint attention, imitation, and pointing are very important pre-verbal milestones which appear late in children with intellectual disability, but which are completely absent in children with autism spectrum disorder. If you look at this particular video that I'm going to show, this child demonstrates classic joint attention, which I told you is a way of when a child looks to and fro from an object of interest to an adult's face. That is joint attention. I'll just play this to you, but remember it appears between 9 months. It appears at 9 months, and this is a milestone which uh, which suggests the beginning of mind reading by the child. This is when the child starts understanding what others are feeling or what others are thinking. Now just watch this video. Sorry. Okay, just give me a second. I'll have to go out of presenter mode to play this video. Sir, can I just log out and log in again, because this video is something that I need to.
No issue. Yes, please.
I hope I can play it now. If not, we will just move on. So I can't play it, but I thought it will be very interesting for everybody to see what exactly joint attention means. This these two videos, they demonstrate what are the most important. Does anybody have any idea how I can play this? Okay.
Can you play them outside your presentation? I mean, individually, without the PowerPoint. Is it possible?
Actually, I've embedded in it in this PowerPoint, and the other file is in my a different laptop.
Okay.
I don't know why it's not playing. It was playing in the other laptop. Okay. So anyway, okay. So moving on to these, I already told you these are two important behaviors: pointing a finger to show at objects and joint attention, which are lacking in autism. Now, I told you that social reciprocity, social communication is an important component for diagnosis of autism. But remember, these skills may be impaired even in a child who has no autism, and there is a specific condition which mimics autism but is not autism. For a child to be labeled as autism, the child should have these complaints, that is impairment in social communication, and they should have this another major component. Then only a child can be labeled as an autistic spectrum disorder. This component is known as RRBs, restricted repetitive behavior. And restricted repetitive behavior can be in the form of stereotypical motor and speech, or it can be insistence on sameness, something like a obsessive compulsive disorder. It can be restricted interests or unusually intense interest in specific toys, story, or movie. Or this is very interesting. Children with autistic spectrum disorder have atypical reaction to sensory input.
ये लाइट बंद कर देना अंदर के, मैं से खुला ही छूट गया.
What atypical reaction to sensory input means? Some sensory inputs, they overreact or they underreact. For example, noise, they scream to noise. They gag to certain smell of food or choke with certain textures. They may be very distressed with certain type of clothing or the feel of water on their body. Or on the opposite, they may crave for some sensory input. And this is the reason why some children with autism, you will find that they engage in repetitive hugging, or they go and touch strangers' hair or face. So these are repetitive restrictive behavior. When they exist with impairment of social communication, then you label these children as autistic spectrum disorder. Obviously, you can always download a very simple to use screening tool for autism, which is MChat, which is freely downloadable, and you can just give it to the parent. It takes about 5 to 10 minutes for them to complete. So this is another way you can rule out autism in children who come with delayed language. So moving on from autism and intellectual disability, you come to a very important chunk of disorder, which results in delay in language. Now, DSM-5 criteria has classified this under an overall heading of communication disorders, under which you have disorder of fluency, disorder of speech sound, disorder of language, and a disorder which is known as social communication disorder. Now, what I told you earlier under autism, the impairment in social communication without the presence of restrictive repetitive behavior is what we call as social communication disorder or pragmatic language disorder. Fluency disorders are stuttering. Now, a child, even in the course of development, many children have disfluency. Now, this is normal. When do you consider stuttering as abnormal? Most children, they have disfluent speech. The sense when they begin a word, they tend to repeat the first letter or the entire word. They have normal disfluency, but any amount of disfluency normalizes by 3 years of age. So any child who has disfluency beyond 4 years requires intervention, and it is considered as a language disorder. Speech sound disorder, I have already talked about apraxia and dysarthria, and phonological disorders of speech sound. Now, this is, I would like to take a few moments here. Phonological disorder in language development is best remembered by the fact that under this heading, children tend to make errors of omission and errors of commission. Now, what this means is that when they speak a word, they may omit the first letter or the last letter of the word. For example, instead of saying banana, children will say nana. Or error of commission, that means they may substitute some letters of the word. So instead of saying thumb, they will say thumb. Or they may completely alter the word. For example, instead of calling elephant, they will say something like ambitan, which has absolutely no relation. But they will mean elephant. They will not, when they say ambitan, they actually mean elephant. So these are phonological disorders. And as I said, they may also be a normal developmental errors at a particular age. But when they are considered atypical and worth intervention, I will come to it soon. But this category of disorder that I have highlighted is the category that is most difficult to pick up. And this is what we have to diagnose when a child comes with language delay. There are different terminologies you will get when you read textbooks. This is a category which is known as specific language impairment or SLIs. Now, how do we suspect SLIs? When you find that a 3-year-old does not have a vocabulary of more than 3 words, you suspect that it is a language disorder and SLI. When you say this MLU means mean length of utterance. Now, between 3 to 4 years, children should be able to speak sentences of 6 to 8 words. So when a child speaks shorter sentence as compared to relative peers, you suspect SLI. When a speech is unintelligible, even at 4 years, you suspect SLI. When you have stuttering even beyond 4 years, you suspect SLI. When the grammar is deviant. Now, what is grammar? Grammar is nothing but a set of rules which decide how words should be combined to convey a meaning. The children with SLI will not be able to follow the set of rules. So ultimately, when they speak, they end up saying a sentence which is completely incomprehensible to the listener. When a child makes errors of omission and commission. Now, as I said, errors of omission and commission are very predictable during the normal course of development. We know when a child says ambitan, it is actually means elephant. But when these errors occurs with different words at different times, then it is not a developmental language problem. It is a disorder. When a child uses unusual strategies of imitation to learn language, like I said, repeating large chunks of phrases that the child hears from either TV programs or from the adults as a means of language, you should know that there is a language problem. And children with language disorder also have what is known as semantics problem in understanding meaning of the word. So when a command is given to the child and the command is purely verbal and not accompanied with a gesture, these children will have difficulty in following that command. So these are some ways to identify a child with developmental
Can I
disorder of
can I
language.
seek one clarification in this chart?
Yes.
The first point, I mean, is it combination of three words or is it related to vocabulary? Because I thought three vocabulary is very little for a 3-year-old child.
Yeah, so it is three separate words. If a child at 3 doesn't even have that lexicon, it is considered worrisome.
Because I thought vocabulary would be something like 150, 200 at this age, and maybe
Yeah.
more.
These children should have a vocabulary of more than 100 words.
Yeah.
But under language disorder, there is something known as disorder of lexicon.
Okay.
When their word library is very limited. And that is why it is a marker of specific language impairment. So can I go on?
Yeah, please go ahead.
So I don't know whether this video will work, but this is a child who had come to me at the age of 4 years. The parents saying that the child has does not speak, and at that it's SLI, and she has been under treatment for the past 4 years. If this video plays, then I'm sure you will all know immediately what an SLI is. No, this is not playing. Maybe at the end, I will again try to connect to a different laptop. So these are the two videos that I've placed here are two examples of language disorders. This, as I said, is SLI, and this is also incomprehensible language. But here we know right away that this is dysarthria and not SLI, because this child has actually spastic diplegia. He is a case of cerebral palsy. So his language, when you hear it, his speech, you will know that it is because of dysarthria. Now, even without the video playing, if you see this child's face, you can right away see that this child is a very expressive child. When she was speaking, she was using her eyes a lot. She was using her fingers. So there is children with SLI can easily be distinguished from children with autism by the fact that children with SLI compensate for their language deficit by using lot of non-verbal gestures, which you do not see in children with autism. Now, a very important statement that all of us should remember, that though most children who have SLI, who have language disorder, were late talkers, but this does not mean that most late talkers go on to have language disorder. What I'm trying to say is that there is a huge difference between what we call as language delay versus language disorder. Language delay is also known as maturational developmental delay. And this by far is the commonest cause of delayed language. So this is where you reassure the parents. Now, when do you consider the possibility of maturational language delay? When you have a family history of language delay, like we did in the case that I presented in the beginning, when they have a poor they come from a poor socioeconomic state. Now, the reason why this is an important risk factor is that in these families, the, the environment is not rich with language. And hence, these children may have a developmental delay in expressive language. Now, a very good rule of thumb to identify when a child has reached the red flag age for language delay is to follow this. A delay becomes disorder when the rate of development falls below 75% expected. I'm going to tell you how to calculate that 75% expected. See, when a skill expected at 18 months is not present in a 24-month-old, this is 18 by 24, which is 75%. Okay, so Take for example, we all know that a child at 1 year should have at least one word vocabulary, 1 to 2 word vocabulary. Now, a 12-month-old child who is expected to have one word vocabulary still has no single word at 18 months. You divide 12 by 18 and it comes to 66%, which is 75%, less than 75% of expected. That means this is a red flag. At 18 months itself, you should start investigating these children for language disorder and not just reassure the parents that it is just a delay and the child will catch up. Now, there are some myths which all of us must understand because we tend to make mistakes in our practice. Many times, delay in language is attributed to gender. Boys, it is said that boys tend to have later language development than girls. Children from bilingual homes, this I've seen very often, even speech therapists reassuring the parents that if you speak 2 languages at home, your child is expected to have delayed language. Later born children, rather than first born, are expected to have delayed language. And children with chronic otitis media with effusion. Now, these are myths. Children who have language delay and any of these conditions are not expected to catch up just because of these conditions. They all require intervention. So, when do you reassure the parents that your child will catch up? You watch for these clues. When the child has isolated expressive language problems and all other domains are normal, his fine motor, gross motor, adaptive skills, they're all normal, then you know that this child has a delay, not a disorder. When the child's cognitive ability appears to be typical for age, then there is then you can expect the child to catch up. When, as I said, expressive language rather than receptive language is affected. If receptive is affected, then it is a very it doesn't have a good prognosis for catch up. When a child has very good non-verbal skills and gestural communication, then then it means that the child has good receptive language, and uh, these children tend to catch up very quickly. And when child has a capacity for pretend play or symbolic thinking, then that's a very good prognostic sign for catching up. So to come to the end, whenever you encounter a child where the mother complains of speech delay or where you suspect speech delay, what is it you need to do? Take a good history to identify any risk factors. Do a physical examination, particularly neurological examination, look for dysmorphic features. Send the child for an audiologic assessment and cognitive assessment, and do a screener for autism. Once you have done this, do a developmental language milestone assessment. Now, most of us are very busy or too lazy to refer to a language developmental chart. But these are some tricks to learn important language milestones just by the numbers. Like at 6 months, the child should be babbling. At 1 year, there are three one. um the child should be able to express one word, should be able to receive and understand one step command, and child should be able to point with an index finger. Now, 1.5 is between 1 year, which is one word, and 2 years, which is sentence. So, a child in between 1 and 2 years will have a jargon speech, neither a word nor a sentence. This is a very, very important language milestone development. A child at 2 will be able to express at least 2 words and will be able to follow two-step commands. Will have a vocabulary of 200. And the child's speech will be at least 50% intelligible, even though there are a lot of phonological errors and disfluency, but at least 50% of it will be intelligible to a stranger. A child at 3 years will have 3 to 5 word sentences, will follow a three-step command like go to the door, take off your slippers, and sit down. So this is a 3-step command. The child's speech will be intelligible at least 3/4, and he will know 3 pieces of information. A child at 4 years is double the child at 2 years. That means his speech should be 100% intelligible. Now, this is the upper limit for language development. Any child who is around 4 years of age and father says that some of what he says I'm not able to understand, remember that is worrisome and you need to investigate. And a child at 5 years should have such felicity with language that he should be able to tell simple stories. So with this, I come to the end and I want to finish by giving 2 case scenarios, and I would be very happy if you people are able to give me the answer. Now, the first case scenario is a 4-year-old boy referred for further evaluation of speech and language. The child is difficult to understand and struggles to express himself. After obtaining a speech and language therapy evaluation, the impression is that most likely the diagnosis is childhood apraxia of speech. Which of the following speech characteristics is most likely to be consistent with this diagnosis in this patient? So we have this child and we suspect speech dyspraxia. Now look at the options and tell me which is most likely to be found in this child's speech. The child may have abnormal pauses between sounds. Child may use excessive fillers in his speech like inconsistent errors in producing words, repetition of individual speech sounds or phrases, and use of excessive behavioral strategies. What would be the right option for speech dyspraxia? Anybody?
Anybody who wishes to make the answer can just unmute or raise hand and I'll unmute them. Dr. Patwa says repetition of individual speech sounds.
Okay, the repetition of individual speech sounds is nothing but echolalia.
No.
But we are talking of a child with dyspraxia.
So this is inconsistent errors in producing words.
Yes, very correct. Inconsistent errors in producing words. Remember, dyspraxia means execution, production of words. That is where the echolalia, the child will be very fluent, will be able to produce words. That you will not find that in dyspraxia. So inconsistent errors in producing words is the right answer. Abnormal pauses between sounds and excessive use of fillers is a type of language disorder which is to do with restricted vocabulary or semantics. So when the semantics is predominantly affected, you have this kind of speech. And repetition of speech sounds, as I said, is echolalia, which is found in children with autism. And use of behavioral strategies can also be seen in children with SLI, because they will try to compensate for their lack of speech felicity by using a lot of gestures. But it is also a strategy which you can see in children with cognitive impairment. The last case scenario, a 9-year-old boy diagnosed as having ADHD has not responded to medication treatment alone. So when reassessed by the therapist feels that the child actually has specific language impairment. Which of the following speech features is most likely to be consistent with the diagnosis of specific language impairment? First option is inability to discriminate high frequency consonants like f, th, and sh. Difficulty getting a point across during conversation and talking around in circles. Repeating phrases. And difficulty in understanding or grade mathematical concepts. Which do you think is the right option for speech language impairment? Anybody? So you can even, so somebody said option 2, that is very correct. These children, because they have word finding problem in word finding, they tend to talk round and round in circles. They cannot come to the point because they don't know many words. They may also, yeah. So what is the first option? What does it suggest? Inability to discriminate high frequency sounds. It suggests mild hearing impairment. It suggests hearing only certain frequencies.
Dysarthria.
Sorry?
Dysarthria.
No.
The first one?
Yes.
First one is not dysarthria. Dysarthria, as I said, is a speech output problem, which is generally because the child has some cerebellar type of speech or spastic speech. That would be dysarthria. So the first option, not able to discriminate between letters, some syllables which belong to high frequency, is actually seen in speech delay because of hearing impairment. So with this, we come to the end of this talk, and let me just summarize that any child who has no defect, who has speech delay with normal hearing, normal cognition, and physical examination, neurological examination normal, consider these 5 situations: hearing loss. I have written absence of canonical babbling. Canonical babbling is the next stage after initiation of babbling. When a child babbles, it is actually beginning of use of consonants. But when child moves on and starts combining consonants with vowels, long strings of consonant with vowels. So ba 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 ba. So all this combination is known as canonical babbling, and this appears around immediately after 6 months of age, and absence of canonical babbling suggests only 2 conditions. As I said, it is normal even in children with severe language impairment. It suggests 1, hearing loss, and in hearing loss children, babbling will be present, but canonical babbling will not be present, and in children with speech dyspraxia. Of course, the other condition is intellectual disability, and without formal assessment, you will use the label global developmental delay instead of ID. Autism is a very, very important and now very common cause for speech delay. And SLI, psychosocial, environmental, poor environment for language development, is a easily correctable and easily identifiable cause of language delay in an apparently normal looking child. Thank you very much.
Thank you, Dr. Meenakshi, for a wonderful deliberation and making the subject so interesting. And I am absolutely hopeful that everybody must have learned a lot from your deliberation. There have been some questions. Uh, how early can you pick up autism, and how early can you administer the MChat?
MChat, the modified one, is designed for children between 16 months to 24 months. It is validated for that age group. And how early you can suspect autism nowadays, people are saying that with good training, you can suspect autism even at 12 months of age. That is the age when you have those 4 key behavioral skills like, joint attention and imitation and pretend play. That is the time when you can start suspecting autism.
I think there are no more questions. If there are any, people can directly ask you at this moment.
Yes, sir. So I see a question here. Yeah, any relation between excessive use of mobile and language delay? So there is no, one second. So there is no direct correlation, a statistical correlation with this, but definitely use of mobile diminishes the richness of language environment that all children must grow in. Because when a child watches a mobile or television, it is a one-way communication. There is no input from the child's side, and the child only learns language by participating in a communication environment with adults. So definitely it affects optimum development of language, but there's no correlation.
So if there are no more questions, once again, profusely thanking Dr. Meenakshi. Yeah, please go ahead.
Ma'am, good afternoon. Prankur this side.
Hi, Prankur.
Hello, ma'am. Ma'am, I wanted to ask about selective mutism. Is it also classified as a language disorder or is it something else?
Actually, selective mutism is a very close differential diagnosis of language disorder. It is not a language disorder per se. So when you are going to confirm the diagnosis of SLI, this is other than autism and cognitive uh, intellectual disability. Selective mutism also should be ruled out. And typically the parents will say that the child just does not talk, but at home he is completely all right. So it's a situational impairment. And it is important to rule this condition out because it has a definite etiology and a very rewarding intervention.
Thank you, ma'am.
You mean the child will not speak in the school and will be absolutely normal at home?
Yes.
So what is the treatment strategy for this kind of a
So
problem?
this is usually a manifestation of anxiety disorder.
Okay.
So this child needs to be sent to a psychologist.
Right. So this time to now end the meeting, and again, thanks Dr. Meenakshi for a wonderful talk. Thanks a lot.
Thank you so much.
Hope to have you again on the platform.
My pleasure.